Whenever a human body is subjected to physical force, the tissue always keeps a record.
Always.
It's an inescapable biological fact. The skin, the joints, the internal organs, the cardiovascular system, they all act as this living, breathing crime scene. Or, at the very least, an objective witness statement to the physical events that just happened.
Right. And in law enforcement or custodial settings or even just chaotic healthcare environments, restraint is sometimes completely necessary.
Yeah.
But we have to understand right out of the gate here, it is never biologically neutral.
No, it always leaves a fingerprint.
Exactly. And because of that, it is certainly never legally neutral.
That concept, the body as a witness statement, that is fundamental to everything we are exploring today. Because when physical force is applied, injury risk and just intense legal scrutiny follow immediately in its wake. Every single bruise has a vector of force. Every abrasion has a friction coefficient. Every alteration in a patient's physiology tells a story about the stress their body was under.
And as clinicians or forensic specialists, your mandate is to read that story with absolute objectivity. You are not there to judge the morality of the restraint.
Leave that to the courts.
Exactly. You are there to translate the physiological record.
And that translation is exactly what we're focusing on today. So I want to explicitly welcome you, the listener, to this deep dive. Whether you are a medical student furiously prepping for your forensic exams or a junior doctor currently trying to survive a busy ED rotation and wondering how to document a really complex police presentation.
Or a senior clinician brushing up on your medico-legal principles.
Right. You are in exactly the right place. We are going to break down the mechanics of human restraint.
But before we dive into the specific mechanisms of force, we need to establish the parameters here. This deep dive is a conceptual exploration of Chapter 15 of Simpson's Forensic Medicine.
The chapter on restraint and control techniques.
That's the one. Our objective is to build your conceptual frameworks and your memory anchors. But, and this is a big but, this is not a regurgitation of the text.
And it is absolutely not a replacement for reading it. Keep your book handy, ideally open to Chapter 15, so you can reference the tables, the diagnostic criteria, and the clinical figures we're going to unpack.
Consider us your guides to the underlying logic of the material. To navigate this efficiently, we're going to look at several modalities of restraint, starting from empty hands all the way to electrical devices.
And for each one, we're going to follow a specific analytical flow. Mechanism, then injury, then interpretation, and finally, legal implication.
Because we want to avoid rote memorization of endless lists. Nobody remembers a list of 30 potential injuries at 3 in the morning in the trauma bay.
I certainly don't.
Right. But if you understand the underlying mechanism of a specific control technique, you can predict the physiological injury.
And taking that a step further, if you can accurately interpret that injury based on the mechanism, you can properly articulate the legal implication in a courtroom or a coronial inquest or an employment tribunal.
That is the absolute essence of clinical reasoning and pattern recognition, connecting the dots between physics, anatomy, and the law.
So let's start laying the foundations. The use of force and conflict resolution. When we talk about law enforcement or security personnel using force, the common phrase thrown around is the use of force continuum.
Yeah, that's the standard terminology.
But I actually think the word continuum is a bit misleading. It implies this straight, predictable line. I prefer to think of it as a volume dial.
Oh, I like that.
Because force isn't an on-off switch. The dial has to be turned up or turned down proportionally to the threat presenting itself in real time.
The volume dial analogy works really well because it captures the dynamic, fluid nature of conflict. The core medico-legal principle governing this entire landscape is the least possible effective force.
Least possible effective force.
Right. Personnel in law enforcement or secure clinical settings, they're legally authorized to use force, but that authorization is strictly conditional. The force must be reasonable, it must be necessary, and it must be proportionate to the threat.
And here is why this matters so much to you, the listener, standing there in the ED. When a restraint event results in harm, or in the worst-case scenario, a fatality, your clinical documentation becomes the absolute bedrock of the subsequent investigations.
It is everything.
Whether it's a criminal trial or a civil suit alleging police brutality, or a coronial inquest into a death in custody, the objective analysis of the type and means of restraint relies almost entirely on the medical evidence you gather in those crucial first few hours.
And to understand what you're documenting, you have to understand the environment in which the injuries actually occurred. What dictates the volume of force used.
The text provides a great framework for this in box 15.1, detailing the variables of conflict.
Yes, these are the situational factors that an officer has to rapidly calculate. And we're talking fractions of a second here when deciding how to respond to a non-compliant individual.
What are they looking at?
They're calculating the comparative age between themselves and the subject. They're evaluating relative sex, size, sheer physical strength, martial skill levels.
Which is just a massive cognitive load during a high adrenaline encounter.
Huge. You aren't just looking at the person. You're standing for imminent danger. You're looking at their hands to see if weapons are involved. But where this intersects heavily with medical vulnerability is when the officer is trying to evaluate the subject's internal state.
Like drugs or alcohol.
Exactly. Is there evidence of intoxication? Is this person exhibiting passive resistance, like just going limp at a protest? Or are they in a state of acute behavioral disturbance where they seem completely immune to pain?
And that altered mental state drastically shifts the dynamic, doesn't it?
It changes everything. An individual experiencing acute behavioral disturbance, perhaps fueled by sympathomimetic drugs like cocaine or meth, they might display extraordinary strength and endurance. The officer perceives a higher threat, so what do?
They turn the volume dial of force up.
They have to. But simultaneously, that individual's physiology is already at the absolute limit. Their heart is racing, their core temperature is skyrocketing, their oxygen demand is massive. By applying high levels of physical restraint to an already physiologically maxed out individual, the risk of catastrophic medical failure just increases exponentially.
This brings us squarely to the clinician's role. Imagine you're on shift. The double doors of the ED fly open. A patient is brought in, surrounded by 4 police officers. The patient is cuffed, sweating profusely, agitated, maybe shouting. The officers are running on pure adrenaline. Perhaps one of them is bleeding.
It is a highly charged, chaotic environment. And the stories about what just happened might immediately conflict right there in the room.
So what do? In that chaos, professional neutrality is your strongest diagnostic tool?
Yes, you are not a judge, you are not a jury, and you are not an investigator. You are a medical professional whose job is to objectively document the physical reality of the patient in front of you.
This means detailing every single abrasion, measuring it, photographing it with a forensic scale if your protocols dictate.
It means recording every complaint of pain in the patient's exact words, in quotation marks, and meticulously tracking vital signs over time.
You're creating a sterile, accurate reflection of the tissue's record, because months or even years later, your notes might be placed side by side with CCTV footage or body-worn camera video or shaky mobile phone footage from a bystander.
And if your notes say small red mark on wrist, but the video shows a 10-minute violent struggle with rigid cuffs, your clinical credibility and honestly the clarity of the whole investigation are severely compromised.
Therefore, specificity is paramount. You must actively look for patterns that correlate with known control techniques.
Let's look at the most fundamental of those techniques, which doesn't involve any weapons or devices at all. It relies purely on the human body.
Right, section 2. Unarmed restraint, often referred to as empty hand techniques. We're talking about arm locks, complex holds, pressure point control, and strikes using knees, elbows, or open hands.
Now, in a controlled, sterile training dojo, an officer learns how to perfectly isolate a joint, say the elbow or the shoulder, to gain immediate mechanical compliance.
But the reality of the street, or a crowded pub at 2 a.m., is profoundly different. The anatomy of a hold becomes highly dynamic.
Extremely dynamic.
Yeah.
The detained person is rarely just standing still, letting it happen. They are moving, twisting, pulling away, dropping their body weight. The kinetic energy in that system is erratic and immense.
So a standard, low-level restraint hold intended just to gently guide someone to a police vehicle can instantly turn into a severe injury.
Right. The officer might be applying a steady, protocol-approved amount of pressure. But if the suspect violently twists their torso in the completely opposite direction, the suspect's own momentum provides the kinetic energy to tear their own rotator cuff or dislocate their shoulder.
And that's exactly the kind of dynamic mechanism clinicians need to be aware of. The injury isn't necessarily a result of an officer actively striking the patient. It is often the erratic kinetic energy of the struggle itself.
You'll see severe joint strains, capsular tears, deep soft tissue injuries that seem totally disproportionate to the intended hold, simply because the biomechanics were altered by violent resistance.
This dynamic unpredictability is why certain empty hand techniques are so intensely scrutinized. And there is one area of human anatomy that is universally recognized as the absolute most dangerous target: the neck.
The neck is a minefield.
Let's talk about vascular neck restraints, sometimes known colloquially as sleeper holds or chokeholds. Many law enforcement agencies around the world have entirely banned these now, and for incredibly sound medical reasons.
The pathophysiology of neck compression is critical for any clinician to understand. The intended mechanism of a vascular neck restraint is to compress the carotid arteries on either side of the neck.
And by doing so, you drastically reduce arterial blood flow to the brain, which induces transient cerebral ischemia, leading to temporary unconsciousness.
The theory being that once the subject is unconscious, they can be safely secured.
Right, the theory. But the anatomy of the human neck doesn't cooperate with that theory. It is incredibly delicate and densely packed. It's not just two isolated pipes you can easily pinch shut.
No, you have the carotid arteries, the jugular veins, the vagus nerve running right alongside them in the carotid sheath. You have the trachea, the delicate hyoid bone, the thyroid cartilage, and the cervical spine, all packed into an area just a few inches across.
The risk of an unpredictable, fatal cascade from neck compression is extraordinarily high. Let's break down those catastrophic scenarios. You mentioned the vagus nerve.
Yes, if pressure is applied to the carotid sinus, which is rich in baroreceptors, the body senses a massive artificial spike in blood pressure. The vagus nerve fires, attempting to compensate by dramatically slowing the heart rate.
And this can cause a profound bradycardia or even a complete vasovagal cardiac arrest, just instantly.
Beyond the neurological and cardiac risks, there is the raw mechanical danger. In a dynamic struggle, a hold intended for the sides of the neck can so easily slip over the anterior neck.
Right over the windpipe.
Exactly. The force can fracture the delicate cartilage of the larynx or the hyoid bone, leading to immediate airway compromise, rapid soft tissue swelling, and asphyxiation.
Or, if the arterial compression is held even a fraction of a second too long, it causes irreversible hypoxic brain injury. The margin for error is measured in literal seconds.
Which brings us to a vital diagnostic anchor for you, the clinician. If you are examining a patient who has been subjected to a neck hold, and this is true even if they seem perfectly fine and are sitting up talking to you.
Yep.
Or if a forensic pathologist is examining a fatality following a struggle, there's a specific finding you must actively hunt for. Examining for petechiae is absolutely mandatory.
Petechiae, the tiny red dots, why are they a cornerstone forensic finding here?
To understand why, you have to look at the hemodynamics of the neck. The jugular veins, which carry blood away from the head back down to the heart, are relatively superficial, and they operate under very low pressure.
Okay.
But the carotid arteries, pumping blood up into the head, are deeper and operate under high pressure straight from the heart.
So, when an arm wraps around a neck, the pressure applied is often enough to easily compress and collapse the low-pressure jugular veins. That stops the blood from draining out of the head.
But that exact same pressure might not be enough to fully compress the high-pressure carotid arteries.
Ah, which means arterial blood continues to be forcefully pumped into the head, but it has absolutely nowhere to go.
Exactly. The venous system becomes massively congested. The pressure in the tiny, delicate capillaries of the face and head builds rapidly until those vessels physically pop. They burst, leaking pinpoint drops of blood into the surrounding tissue.
And those tiny, non-blanching spots of hemorrhage are petechiae.
If a patient has experienced neck compression, a cursory glance is medical negligence. You must meticulously examine the skin of the face, particularly around the eyelids and the cheeks.
You must check behind the ears and inspect the scalp. You must use a pen light to look inside the mouth at the intraoral mucosa, checking the inside of the lips and the soft palate.
And most critically, you must examine the eyes. The conjunctiva and the sclera are prime locations for this hemorrhagic bursting. I strongly encourage you to look at figure 15.1 in your textbook.
It's a striking image.
It shows a classic, profound scleral hemorrhage that developed 2 hours after a neck compression event. It is an unmistakable visual of capillary failure.
And that 2-hour timeline you just mentioned is a great point. Petechiae don't always appear the second the hold is released. The blood takes time to extravasate and become visible on the surface.
That's why keeping the patient for observation and repeating the physical exam is so important.
Now, speaking of life-threatening mechanisms that might not be immediately obvious, we need to unpack a concept that is arguably the most critical in modern forensic analysis of restraint: positional asphyxia.
Positional asphyxia, fundamentally, is a state of respiratory impairment caused directly by the physical position in which a person is placed or trapped.
In the context of law enforcement or healthcare restraint, it typically occurs when an individual is held in a posture that mechanically prevents adequate respiratory excursion.
Let's visualize the mechanics of breathing for a second. For air to enter your lungs, your chest cavity has to physically expand. Your ribs swing outward and upward, and your diaphragm, that massive sheet of muscle at the bottom of your rib cage, contracts and pulls downward.
Creating negative pressure that sucks air in.
Exactly. Positional asphyxia happens when that mechanical expansion is blocked. The chest wall or the diaphragm becomes splinted.
Imagine a scenario where multiple security personnel are restraining a violent individual on the ground. To gain control, officers might kneel or lean heavily on the posterior thorax, the back.
That external mechanical weight physically prevents the rib cage from expanding against the floor.
But it's rarely just one factor that causes the death, is it? The text outlines specific risk multipliers. When we talk about positional asphyxia, we are usually looking at a catastrophic stacking of variables.
Let's build that stack. The foundation is usually the prone position. The individual is lying face down on a hard surface. Now, by itself, lying prone doesn't stop you from breathing. We sleep on our stomachs all the time.
Right. But then add the first multiplier. The hands are pulled back and cuffed behind the back.
This alters the biomechanics of the shoulder girdle. It pulls the shoulders back and effectively locks the anterior chest wall against the ground, drastically reducing its ability to expand.
Now add the second multiplier. Massive central obesity. If an individual carries significant weight in their abdomen, lying prone means that static weight is pressed between the floor and their internal organs.
The physics of that are devastating. The abdominal fat acts as a hydraulic press, pushing the abdominal contents, the liver, the stomach, the intestines upwards, directly against the underside of the diaphragm.
So the diaphragm is trying to pull down to draw in a breath, but it is fighting against the massive upward pressure of all that displaced abdominal mass.
Then factor in underlying disease. Maybe they have chronic obstructive pulmonary disease, COPD, or an enlarged failing heart. Their physiological reserve is already totally depleted.
And finally, the spark that ignites this cascade. The struggle.
The person is terrified, angry, or in a state of excited delirium. They are violently thrashing against the restraint. This massive muscular exertion exponentially increases their cellular oxygen demand and simultaneously their production of carbon dioxide.
So we have a physiological nightmare. Their oxygen demand is at its absolute peak precisely when their mechanical ability to supply that oxygen is severely restricted.
This mismatch isn't something the human body can tolerate for long. It leads rapidly to profound hypoxia, lack of oxygen in the blood.
Followed by hypercapnia, the dangerous buildup of carbon dioxide, which turns the blood acidic.
This acidosis, combined with the hypoxia and the massive surge of adrenaline from the struggle itself, creates a highly irritable heart. The myocardium becomes unstable, leading to lethal cardiac arrhythmias, ventricular fibrillation, and ultimately death.
It's a terrifying, often very rapid physiological cascade, and understanding it is paramount because it informs how officers are trained today. The goal is to get subjects off their stomachs and into a seated or recovery position as soon as mechanically possible.
Precisely. Once they are cuffed, roll them on their side or sit them up.
All right, we've spent a lot of time on empty hands and body weight. Let's transition to the introduction of tools. We are moving into mechanical restraint, specifically handcuffs.
Handcuffs are so ubiquitous in law enforcement and even on television that we often view them as benign tools of the trade. But from a clinical and forensic perspective, they are specialized instruments that apply highly concentrated force to vulnerable anatomy.
There are three main types you'll encounter. First, traditional handcuffs, which most people picture. 2 metal wrist pieces connected by a short, flexible chain. Second, rigid cuffs, where the wrist pieces are connected by a solid, unbending metal bar or a hinge.
And third, plastic cuffs, which are essentially heavy-duty nylon cable ties, often used in mass public order or riot situations because they're cheap, light, and easy to carry in bulk.
Let's focus on the rigid cuffs because their design introduces a unique biomechanical risk.
The solid metal bar between the wrists acts as a lever. It allows an officer to apply controlled directional force across the detainee's wrist to gain physical compliance or direct their movement.
And the locking mechanism itself is crucial to understand. Handcuffs don't just snap shut to a fixed size. They operate on a ratchet mechanism.
Once the officer pushes the single swinging arm through the main body of the cuff, it clicks past a series of teeth. It can always get tighter, but it can't get looser without a key.
That ratchet mechanism is the source of significant medico-legal inquiry. If a detainee is non-compliant, if they are pulling their arms apart, twisting their wrists, or thrashing around in the back of a police cruiser, the cuffs can progressively tighten.
Every time they twist and press against the mechanism, the ratchet clicks tighter. The space between the steel and the skin vanishes, and the rigid metal begins to crush the underlying tissues.
So, as a clinician, you're looking for pattern recognition. When you are examining a patient whose wrists have been cuffed, your documentation needs to be meticulously anatomically specific. Let's start with the surface level. Soft tissue injuries.
You will commonly observe reddening, linear abrasions, and bruising that is highly localized to the radial and ulnar borders of the wrists. The bony prominence is on the thumb side and the pinky side.
Because the movement of the wrist within the cuff, or the cuff sliding up and down the arm during a struggle, causes characteristic frictional trauma.
Exactly. And if the cuff was applied with high kinetic energy, or if the edges of the metal were particularly sharp, you might see deep superficial lacerations requiring closure.
But the real damage often occurs beneath the skin. The neurological injuries associated with handcuffs are fascinating, incredibly specific, and a frequent cause of litigation against police forces. We are talking about handcuff neuropathy.
This is a critical clinical presentation. The superficial nerves of the wrist are highly vulnerable because they lack significant protective padding. They run just under the skin, directly over hard bone.
So the tight application of a steel cuff can literally crush these nerves against the radius or the ulna. Think of it like a garden hose being stepped on against a concrete driveway. The flow of information is pinched off or severely disrupted.
And what does that feel like for the patient? The clinical presentation usually involves hyperesthesia, an intensely uncomfortable, burning sensitivity to even light touch, or outright numbness and tingling.
Like hitting your funny bone, but it doesn't fade away.
Right, and it follows a very specific mapping. You are looking for sensory deficits in the cutaneous distribution distal to the cuff. Specifically, you will see this in the superficial sensory branches of the radial nerve, affecting the back of the thumb and hand, and the ulnar nerve, affecting the pinky finger side.
How long does this last? If a patient comes into the ED saying their thumb is numb, what's the prognosis?
The prognosis generally depends on the severity of the crush injury, what we call neuropraxia versus axonotmesis. In many cases, the nerve is just bruised, the myelin sheath is irritated, and the numbness is transient, fully resolving over a few weeks.
But not always.
Now, persistent cases are not uncommon. If the pressure was severe enough to cause Wallerian degeneration of the nerve axon, recovery can take months. If a patient continues to experience numbness or neuropathic pain after several weeks, formal nerve conduction studies are required to objectively evaluate the extent of electrical disruption.
Okay, so we've covered the soft tissue and the nerves being crushed against the bone. What about the bone itself? Is it actually possible to break a wrist just by applying handcuffs?
It is rare, but it absolutely occurs, and a forensic clinician must maintain a high index of suspicion. The mechanism is almost never the initial application of the cuff. It is secondary to a violent, high-leverage struggle while the rigid cuffs are firmly applied.
The anatomy makes certain bones structural weak points in this scenario.
The most vulnerable anatomical structure is the styloid process, the bony bumps that stick out on the sides of your wrist, particularly the ulnar styloid process.
So if a patient presents post-restraint with marked pinpoint tenderness over the styloid, a loss of normal range of motion, or swelling and bruising that seems disproportionately severe compared to standard cuff marks, you must suspect a bony fracture and order radiographs.
I want to point you again to the textbook. Figure 15.2 provides a phenomenal visual of this. It shows a profound indented imprint of the handcuff mechanism, surrounded by deep bruising and abrasion, which overlaid an ulnar styloid fracture following a severe struggle.
That image reinforces why clinical precision is non-negotiable. You cannot write a chart note that simply says, patient complains of wrist pain, small red mark.
Never. You must palpate the styloid processes. You must check the capillary refill and distal pulses to rule out vascular compromise. You must map the sensory deficits using a two-point discrimination test. You are building the objective medical record that will either confirm or refute the accounts of the struggle.
The tissue keeps a record, and it's our job to read it carefully. All right, we've talked about empty hands and metal cuffs. Now let's explore tools designed specifically to deliver kinetic energy. We're moving to Section 4, batons.
Batons are impact tools. Their entire purpose is to deliver focused, blunt force trauma to gain behavioral compliance. In the UK, and similarly in many global jurisdictions, law enforcement generally utilizes two main types of batons.
First, you have the friction lock baton, often recognized by brand names like ASP. This is made of heavy steel. It's telescopic, usually featuring two inner tubes that extend from a handle and lock into place with a sharp flick of the officer's wrist. It is heavy, dense, and rigid.
And second, you have the acrylic patrol baton, which is a solid fixed piece of polymer or acrylic, typically between 22 and 26 inches long.
The distinction in materials is important because it changes the physics of the strike, which in turn dictates the tissue damage.
Force equals mass times acceleration. A heavier, rigid steel baton, swung with the exact same velocity as a lighter acrylic baton, transfers significantly more kinetic energy.
Furthermore, that energy is concentrated into a very small surface area, the narrow cylinder of the steel tube.
This massive energy transfer into a tiny footprint has the capability of causing devastating blunt force trauma. If applied incorrectly, it can shatter bone, rupture organs, cause depressed skull fractures, and easily result in death.
Because of this lethal potential, the deployment and targeting of batons are governed by incredibly strict protocols. Officers are trained to strike specific anatomical triage zones.
And for a forensic physician, understanding these zones is crucial. It allows you to differentiate between the intended, authorized use of force and an unintended, accidental, or frankly excessive outcome. The body is divided into low, medium, and high-risk areas.
Let's map those out. The intended primary targets for baton strikes are the low-risk zones.
Correct. The low-risk zones are primarily the large muscle masses of the lower and upper limbs. Specifically, officers are trained to target the thick muscles overlying the common peroneal and tibial nerves in the legs or the radial and median nerves in the arms.
The mechanism here isn't to break the leg, it's pain compliance and motor dysfunction.
The officer strikes the muscle belly. The kinetic energy sends a massive shock wave through the muscle tissue, impacting the major nerve running beneath it.
It induces an intensely sharp pain and causes the muscle to temporarily cramp or fail. The person's leg literally gives out from under them.
When examining a strike to a low-risk zone, the expected medically acceptable complications include significant localized bruising, deep muscle contusions, and occasionally hairline cortical fractures of the underlying bone if the strike was particularly forceful.
And the motor dysfunction should be transient, resolving as the nerve recovers from the shockwave. Then we escalate the volume dial. We move to the medium risk zones, which are not intended as primary targets, but might be struck in a dynamic moving conflict.
Medium risk zones include the joints, the knees, ankles, wrists, and elbows, as well as the hands, the upper arms, and the clavicles.
The medical vulnerability here is that there is very little muscle mass to absorb and dissipate the kinetic energy of the baton. The steel impacts almost directly against bone and delicate joint capsules.
A strike to these areas predictably causes severe bone fractures, joint dislocations, and massive soft tissue avulsions where the skin is sheared away from the bone.
And finally, we have the high-risk zones. These are the absolute do-not-target areas. Striking these areas is generally considered an application of lethal force, justified only in scenarios where the officer's or the public's life is in immediate danger.
The high-risk areas include the head, the neck and throat, the spine, the loins over the kidneys, and the entire abdomen.
The forensic focus here is on the severe risk to internal structures. A blunt force strike from a heavy steel baton to the abdomen is like hitting a water balloon with a baseball bat.
The energy transmits straight through the abdominal wall into the organs.
Doesn't bounce off.
No, it can cause catastrophic damage to solid, blood-rich organs, resulting in deep liver lacerations or splenic rupture, leading to massive internal hemorrhage.
It can also cause a blowout rupture of hollow organs, like the stomach or the small bowel, spilling digestive contents into the peritoneal cavity and causing rapidly fatal peritonitis.
And a strike to the head carries the immediate obvious risks of depressed skull fractures, laceration of the middle meningeal artery, leading to an epidural hematoma, and severe traumatic brain injury.
So when a patient presents with baton injuries, how do you document them? You can't just write bruise on thigh. You need to utilize specific, descriptive forensic terminology. Pattern recognition is your best friend here.
The classic hallmark pattern of a cylindrical baton strike is known as tramline bruising. Understanding the physics of this bruise is essential.
When a rigid cylindrical object strikes the skin at high speed, it forcefully compresses the blood vessels directly beneath the point of impact. It essentially crushes the blood outward, away from the center line.
Yes. The blood is violently displaced into the margins. The central area of direct impact often appears pale because the vessels have been emptied or completely crushed shut.
But at the edges of the strike, the violently displaced blood bursts the surrounding capillaries.
Exactly. This leaves a central pale strip flanked by two parallel linear lines of bruising. the tram lines.
It's a textbook forensic indicator. You also need to look for circular imprint bruising. This occurs when an individual is jabbed or thrust with the very tip of the baton rather than struck with the side.
The kinetic energy is concentrated into a circle the size of a coin. Figure 15.4 in the text provides a perfect visual example of this circular imprint, demonstrating exactly how the tool maps perfectly onto the damaged tissue.
You should also anticipate deep lacerations when a baton strikes tissue directly overlying a sharp, bony prominence, like the shin bone or the skull.
The skin is caught between the steel baton and the unyielding bone, and it simply splits under the immense tension, creating a wound that often looks like it was cut with a blunt knife.
We've spent a lot of time on kinetic energy. Blunt force, leverage, mechanical crushing. But law enforcement also relies heavily on chemical control. Let's shift gears and examine Section 5, irritant sprays.
Irritant sprays are deployed to render individuals or groups temporarily incapable of purposeful action without needing to engage in hand-to-hand physical combat. We are moving away from the physics of force and entering the realms of pharmacology and chemistry.
The two predominant agents utilized globally by police services are CS spray and PV. Let's start with the chemistry of incapacitation. CS spray is incredibly common, but its actual physical state is widely misunderstood. What exactly is CS?
CS stands for O-chlorobenzylidine malonitrile. What's truly fascinating from a chemical perspective is that at room temperature, CS is not a gas. It is actually a white crystalline solid powder.
Wait, really? A powder?
Yes. To be deployed from a handheld canister as an aerosol spray, that solid powder must be dissolved in a liquid organic solvent.
And the solvent of choice is typically methyl isobutyl ketone, or MIBK.
Correct. When an officer deploys CS spray from a distance of up to 3 or 4 meters, they are not spraying a cloud of gas. They are delivering a pressurized liquid aerosol, a mist of MIBK solvent carrying the dissolved solid CS particles directly at the subject's face, specifically targeting the eyes, nose, and mouth.
The physiological effects are dramatic, agonizing, and immediate. But before we break down the clinical triage of a sprayed patient, there is a fascinating, almost bizarre caveat mentioned in the text about CS spray that I think surprises a lot of people.
It is a critical operational and medical fact. Approximately 10% of the population possesses a natural immunity to the incapacitating effects of CS spray.
Which is wild to think about. An officer might deploy their primary chemical deterrent perfectly, hitting the subject right in the eyes. They expect the subject to drop to the ground in agony. Instead, the subject just blinks, wipes their face, and continues their aggressive behavior.
It's like throwing a glass of water on them and asking, "Is it raining?"
It is a terrifying scenario for an officer, and it drastically alters the trajectory of the conflict resolution, often forcing an immediate escalation to a higher level of force, like a baton or a taser.
It is currently impossible to predict who will be a non-responder. It is just a genetic and physiological roll of the dice.
Okay, but for the 90% of people who do respond, it is a profoundly unpleasant experience. Let's run through the clinical triage. Table 15.2 in the text is a goldmine for this. Let's dissect the pharmacology by anatomical system. First, the eyes.
The ocular effects are the primary mechanism of incapacitation. You will observe profound blepharospasm.
Spasm.
Right, this isn't just blinking. It is an involuntary, spasmodic, incredibly tight closure of the eyelids. The brain registers the severe chemical irritation and forcibly clamps the eyes shut to protect the cornea. The patient literally cannot pry their own eyes open.
Associated with that, you will see massive lacrimation, uncontrollable tearing as the eye tries to flush the chemical out. You'll see a conjunctival erythema, severe burning pain, and photophobia, where light itself causes agonizing pain.
And we must not forget the mechanical risk. The physical force of a high-pressure jet of liquid hitting the eye at close range can cause direct, blunt trauma to the ocular surface.
Furthermore, patients often instinctively and frantically rub their eyes with their hands or contaminated clothing, which grinds the crystalline CS powder into the eye, causing severe corneal abrasions.
Moving to the respiratory tract. When the patient inevitably inhales the aerosol, what happens?
The mucous membranes are immediately irritated. Expect profound rhinorrhea, a running, nose-violent sneezing, coughing, and a sensation of a tightening chest or shortness of breath.
In rare, severe cases, or in patients with pre-existing hyperreactive airways like asthma, the irritation can trigger severe bronchospasm, laryngospasm, and there are documented cases of delayed pulmonary edema developing up to 24 hours post-exposure.
And then there's the skin. The CS powder burns, but the solvent itself, the MIBK, is also highly reactive.
The solvent strips the natural oils from the skin and combined with the active ingredient causes a severe burning sensation and erythema, resembling a really bad sunburn.
In individuals with sensitive skin, or if the chemical is trapped under clothing and sweat, it can cause severe chemical burns and blistering.
Generally, the acute effects on the eyes and skin last up to 2.5 hours, while the acute respiratory effects begin to subside after about 30 minutes in fresh air.
So that's CS, but many forces have transitioned to PAVI. How does weaponized hot sauce differ from CS powder?
PS stands for pelargonic acid vanillylamide. It is a highly concentrated synthetic equivalent of capsaicin, which is the active heat-producing compound found in chili peppers.
The key difference is often in the delivery system. Unlike the aerosolized drifting mist of CS, PAVI is generally delivered as a targeted, cohesive liquid jet aimed directly at the eyes.
It's more like a super soaker stream than a hairspray mist.
Exactly. This reduces the risk of cross-contamination in the environment or affecting bystanders. It induces extreme, fiery pain in the eyes and immediate blepharospasm.
The broad clinical effects on the respiratory system and skin and the medical management are largely similar to CS, though it's worth noting there's slightly less long-term epidemiological research on PAVIA compared to the decades of data we have on CS.
So imagine you are the clinician in the police custody suite or the emergency room. A patient is brought in screaming, their eyes clamped shut, their face red. What is your management protocol?
The primary management is largely supportive, observational, and environmental. There is no magic antidote. The most important initial action is to stop the continued chemical exposure.
You must remove the patient from the contaminated environment and place them in a well-ventilated area with a free flow of cool, fresh air. Use a fan if available.
And dealing with their clothing is a massive safety issue for the staff, right?
Absolutely. The patient's clothing is soaked in the solvent and the active powder. As the solvent warms up, it off-gases. If you leave a sprayed patient in a small, enclosed examination room, the fumes will begin to affect the nurses and doctors, causing secondary contamination.
Contaminated clothing must be carefully removed and securely sealed in plastic bags.
Once the environment is secure, you conduct a full clinical assessment of the eyes, utilizing fluorescein staining to check for corneal abrasions, examining the oral cavity, auscultating the respiratory system for wheezes, and checking the skin for blistering.
The general rule of thumb is, if severe effects on the eyes or respiratory system persist without improvement for more than 6 hours, that warrants an urgent specialist referral to ophthalmology or respiratory medicine.
It's a great reminder that treating the patient also requires intense situational awareness to protect your team from secondary exposure. All right, let's move to Section 6, impact rounds. We are returning to the realm of kinetic energy, but this time it's ballistic. We are talking about projectiles fired from adapted firearms.
When we use the term impact rounds, we are referring to a variety of less lethal projectiles. Historically, you might hear them called plastic bullets or rubber bullets. Modern iterations are often referred to as baton rounds or attenuating energy projectiles known as AEPs.
To understand the forensic injuries they cause, the core physics of their less lethal design is vital to understand, because the fundamental design of a standard lead bullet fired from a handgun is meant to penetrate tissue. It achieves this through high velocity and a very small surface area, allowing it to slice right through skin and bone.
How do impact rounds change that ballistic math?
They drastically alter the variables of the physics equation. Impact rounds utilize materials of lower density, like polyurethane or specialized plastics. They create a much larger, blunter projectile, often the size of a small soda can or a large cylinder, and they fire it at a significantly lower velocity than a standard bullet.
The intended design goal, large size, low weight, low velocity, is meant to disperse the kinetic energy over a much wider surface area of the body upon impact.
The goal is to induce a massive, localized blunt force trauma, like being punched by a heavyweight boxer, to cause severe pain and temporary incapacitation, but specifically without penetrating the dermis.
This minimizes the risk of severe internal hemorrhage or fatal organ perforation.
But as forensic specialists know all too well, theoretical design is one thing. The chaotic reality of a riot or a volatile public order situation is entirely another. The dynamic variables of the real world frequently change the medical outcome from less lethal to life-threatening.
The primary issue is accuracy in ballistics. The safe operating range for public order use of these rounds is typically between 20 to 40 meters. But due to their large size, blunt shape, and poor aerodynamic profile, these rounds are relatively inaccurate, especially over distance or in windy conditions.
Furthermore, they are highly prone to a ballistic phenomenon known as tumbling. A standard bullet spins smoothly like a perfectly thrown American football, keeping its nose forward. A large cylindrical baton round might lose stability in the air and begin to tumble end over end.
Which completely alters the impact physics.
Exactly. Instead of hitting nose first with a predictable surface area, a tumbling round might strike the target sideways. This focuses the kinetic energy along a narrow edge, drastically increasing the focal pressure and the risk of skin penetration or bone fracture.
Additionally, in rapidly moving dynamic situations, an officer might be forced to fire from a much closer distance than the recommended 20 meters. This drastically increases the velocity and kinetic energy at the exact moment of impact.
And because of that poor accuracy, the round might strike an unintended, highly vulnerable part of the anatomy. The designated target zone for impact rounds is generally the lower torso or the legs. But the clinical complications we see in trauma centers tell a different story. The chest and the head frequently take the hits.
And when a high-energy projectile impacts those zones, the trauma is profound. While fatalities from impact rounds are uncommon compared to live ammunition, they are well documented in forensic literature, principally resulting from severe head and chest trauma.
Even though the system is expressly designed to avoid penetrating the skin, the sheer massive blunt force applied to the thorax can be devastating.
The energy transfer can cause multiple rib fractures, sternal fractures, and devastating pulmonary contusions, where the lung tissue itself is bruised and the alveoli fill with blood, severely compromising oxygen exchange.
If the round impacts directly over the heart at a specific vulnerable moment in the cardiac cycle, it can theoretically cause commotio cordis instant cardiac arrest from blunt trauma.
And an impact to the head is even more catastrophic.
The skull is a rigid box. A blunt impact from a heavy plastic round can cause depressed skull fractures, driving bone fragments into the brain tissue. It can shear bridging veins or arteries, causing rapidly expanding subdural or epidural hematomas that are fatal without immediate neurosurgical intervention.
The critical forensic takeaway here is that the label less lethal absolutely does not mean non-lethal. The kinetic energy is still immense.
A sobering point that requires clinicians to maintain a high index of suspicion for internal injuries, even if the skin isn't broken. Let's pivot to a completely different and entirely unpredictable type of restraint in Section 7, dogs. We are talking about biological restraint.
Law enforcement agencies globally use highly trained canines to track, contain, and physically control fleeing or violent individuals. From a tactical perspective, a police dog is an incredibly effective tool, but from a clinical and forensic perspective, it is a biological weapon.
A canine bite is a complex trauma mechanism. Every single dog bite encountered in a custody suite or emergency department requires meticulous, thorough medical assessment and aggressive prophylactic treatment.
The primary concern here isn't just the raw mechanical crushing force of the dog's jaws, though that is significant. A large German Shepherd can exert tremendous pounds per square inch of pressure, enough to crush small bones or cause massive muscle avulsions as they grip and shake.
But the real insidious clinical focus is the profound risk of aggressive infection.
The oral microbiome of a canine is a veritable soup of dangerous, fast-acting pathogenic bacteria. We are particularly concerned with organisms like Pasteurella multicida, various virulence of Staphylococcus, Streptococcus, and Capnocytophaga canomorsus.
And the delivery mechanism for these bacteria is perfectly designed to cause deep tissue infections.
Precisely. The dog's canine teeth act like living biological hypodermic needles. When the dog bites, those teeth puncture the skin and drive these pathogenic bacteria deep into the underlying muscle, the tendons, and the fascial planes.
The surface puncture wound might look relatively small, just a tiny tear in the skin, but beneath that, a deep pocket of bacteria has been injected into a warm, dark, blood-rich environment.
We're not just talking about minor localized infections that require a quick course of oral antibiotics. The text explicitly warns about severe, limb-threatening complications.
The primary fear is necrotizing fasciitis, what the public often calls flesh-eating bacteria. Once these virulent bacteria are injected deep into the fascial planes, they can spread at an astonishing rate, sometimes advancing centimeters every hour. They release toxins that destroy the tissue, causing widespread necrosis.
There are well-documented medical cases where individuals have lost entire limbs to amputation or even died from rapidly spreading systemic sepsis following a police dog bite that wasn't aggressively managed.
Therefore, the standard of care is rigorous. It involves high-pressure, copious irrigation of the puncture wounds to physically flesh out bacteria. It requires objective, precise documentation of the wound depth and location. Often, it requires surgical exploration and extensive surgical debridement of dead tissue.
And broad-spectrum prophylactic antibiotics are absolutely mandatory. A wait-and-see approach with a dog bite is clinical malpractice.
Beyond the critical medical management, there is a fascinating forensic angle that sometimes arises in these cases. What happens if the origin of the bite is legally disputed? Imagine a scenario where a suspect, fleeing through a neighborhood, claims that a random stray dog bit them before the police canine unit ever arrived on the scene.
In those complex disputed instances, the quality of your initial clinical documentation is paramount. Photographs, taken with a standardized forensic scale right next to the bite mark, are mandatory before any wounds are cleaned or sutured.
If the source of the bite is challenged in court, the case will likely involve a forensic odontologist or a specialized forensic veterinarian.
And what are they looking for? They aren't doing DNA swabs of dog saliva, are they?
Sometimes DNA can be utilized if swabbed immediately, but primarily they rely on bite mark analysis. They analyze the pattern of the punctures, the specific intercanine distance, the measurement between the puncture wounds left by the upper fangs, and the overall jaw mechanics displayed by the injury.
By comparing these precise metrics, they can often provide a definitive expert opinion, matching the specific police dog in question to the unique injury pattern on the suspect, effectively refuting the stray dog defense.
It's incredible how many diverse scientific disciplines converge in the field of forensic medicine. Okay, let's move into one of the most heavily scrutinized, misunderstood, and scientifically complex areas of modern policing. Section 8. Conducted energy devices, most universally known by the brand name tasers.
This is an area where physics, cardiology, neurology, and the law all collide. Tasers, which is an acronym for Thomas A. Swift's electrical rifle, are battery-operated devices engineered to deliver brief, high-voltage, low-amperage pulses of electricity into the human body.
They are a critical, central component of the less lethal continuum, particularly designed for incapacitating violently disturbed individuals from a safe distance. Models like the X26 and the newer X2 are widely deployed around the world.
To understand the medical implications, we need to clearly differentiate exactly how electricity is being used to control human movement. A taser isn't just a generic shock box. There are two very distinct, physiologically different modes of operation: drive-stun mode and probe mode.
Let's define the mechanics of each clearly. In drive-stun mode, the device is used like a traditional stun gun. The two fixed electrodes at the very front of the taser are pressed directly against the subject's clothing or bare skin, and the trigger is pulled.
So the electrical circuit is completed across an incredibly small distance, just the inch or two between those fixed electrodes on the weapon.
Exactly. Because of this tiny electrode separation, the electrical charge does not penetrate deeply into the body. It only affects the superficial sensory nerves localized to that exact spot where the weapon is pressed.
The mechanism here is purely localized pain compliance. It hurts intensely, causing a severe burning sensation, but it does not physically override the nervous system. The person can still swing their arms, kick, and fight.
Probe mode, however, is an entirely different, highly engineered physiological event. This is where the device earns its reputation.
Yes. In probe mode, the officer fires a cartridge attached to the front of the device. Compressed nitrogen propels two small metal darts, or probes, which travel at approximately 40 to 50 meters per second. These probes are essentially tiny fishhooks with microbarbs. They embed firmly into the subject's skin or heavy clothing and remain physically connected to the weapon by fine insulated copper wires.
And here is the crucial physical difference. As the probes fly through the air, they spread apart. The lower probe drops at an angle, so when they hit the body, they might be a foot or two apart.
That spread is the key to incapacitation. The electrical circuit is now established across a much wider area of the human body, say, from the upper chest down to the thigh, or across the entire broad span of the back.
This wide electrode separation allows the electrical current to penetrate deeper and interact with the motor nervous system.
It's like a rogue drummer suddenly hijacking the body's electrical rhythm. The taser delivers rapid pulses, typically around 19 pulses per second.
And those pulses mimic the body's own electrical signals, but at a massive, chaotic volume. It induces profound, involuntary tetanic contraction of the skeletal muscles across that entire wide area.
This is called neuromuscular incapacitation, or NMI. The subject's brain is literally locked out of controlling their own skeletal muscles. Their legs lock up, their torso seizes, and they instantly fall to the ground.
The incapacitation is absolute and immediate. However, as soon as the 5-second electrical cycle ends, the muscles relax and recovery begins almost immediately.
But the complications surrounding this device can be severe and multifaceted. The text, specifically Cable 15.3, laid out the primary, secondary, and systemic risks. Let's break those down, starting with the primary complications.
Primary complications largely stem from the ballistic nature of the probes themselves. Remember, these are small, sharp projectiles flying at high speed. If fired at the face, the neck, or the groin, they can penetrate highly vulnerable, soft anatomy.
There are well-documented forensic cases of probe penetration directly into the globe of the eye, causing permanent blindness, penetration through the thin temporal bones of the skull directly into the brain tissue, and deep penetration into the testes or even the pleural cavity, causing a pneumothorax.
And when a clinician removes these probes in the ER, they must be careful because of those microbarbs. You can't just yank them out like an IV line or you'll tear the dermis. You have to pull the skin taut and snap them out with a quick, firm motion.
Then there are the secondary complications. These occur not from the electrical current or the darts, but entirely from the resulting neuromuscular incapacitation.
When a person loses all motor control instantaneously, their protective reflexes are entirely bypassed. They cannot put their hands out to break their fall. If they are standing on hard concrete, running at a sprint, or standing at an elevation like a wall or a staircase, the resulting uncontrolled deadweight fall can cause devastating secondary trauma.
We see severe, sometimes fatal, blunt force head injuries, traumatic brain bleeds, spinal compression fractures from awkward landings, and major joint dislocations simply from the sheer force of hitting the ground without defensive bracing.
Now, let's take a deep dive into the most scientifically debated systemic risk, the cardiac risks. This is where forensic pathology intersects heavily with electrophysiology, cardiology, and toxicology. The textbook discusses the highly controversial risk of rapid ventricular capture.
This is the central question of nearly every taser-related lawsuit. Can the electrical pulse of a taser fired into the chest physically interfere with the heart's internal electrical rhythm and cause a heart attack?
The scientific consensus, built from animal models, epidemiological data, and independent medical advisory committees, is that it is prudent and medically necessary to assume there is a possibility that taser discharges across the anterior chest can induce rapid ventricular capture.
This means the external electrical pulse essentially overrides the heart's sinoatrial node, driving the heart into a lethal, chaotic arrhythmia like ventricular fibrillation.
But the nuance here is critical. It's not a uniform risk for every human being. If you taser a healthy 20-year-old athlete in a calm laboratory setting, the cardiac risk is microscopically low.
True, but that is the critical point for forensic pathologists and clinicians investigating real-world cases. Tasers are almost never deployed in calm, controlled laboratory settings. They are deployed in physically violent, emotionally charged, terrifying environments. The cardiac risk skyrockets exponentially when you combine the electrical discharge with an already deeply compromised vulnerable physiology.
We are talking about the catastrophic stacking of variables again.
Exactly. Consider a subject with undiagnosed underlying ischemic heart disease. Now, add intoxication with illicit sympathomimetic drugs, like massive doses of cocaine or methamphetamine, which are highly arrhythmogenic, meaning they make the heart prone to irregular beats on their own.
Now, add a state of acute behavioral disturbance or excited delirium where the individual has been violently fighting multiple officers for 5 minutes.
In that individual, their endogenous catecholamine levels, their adrenaline, are completely maxed out. Their heart is pounding at 180 beats per minute, screaming for oxygen, and it is highly electrically irritable.
And at that exact moment of maximum physiological vulnerability, you introduce a chaotic 50,000-volt electrical discharge across the chest. The addition of that taser discharge, acting as the final rogue electrical impulse, combined with the profound acidosis and extreme physical exertion of the struggle, can precipitate a sudden, fatal cardiopulmonary arrest.
It perfectly illustrates why restraint-related deaths are among the absolute most scrutinized, difficult, and complex cases in all of forensic medicine. As an investigator or a clinician, you cannot point to a single factor. You can't just say the taser killed him or the drugs killed him.
You have to intricately weave together the baseline physiology, the precise toxicology report, the scene findings, the duration of the struggle, and the digital download data from the device itself.
It demands absolute objectivity, careful methodical analysis, and the strict avoidance of simplistic single-cause explanations.
All right, let's move to our final specific topic, Section 9. Spit guards, which are also frequently referred to as spit hoods or bite masks.
Compared to tasers or batons, the device itself is incredibly low-tech and simple. It is generally a lightweight synthetic mesh bag placed loosely over the head of a restrained person. It usually features a reinforced, semi-impermeable panel at the front that covers the mouth and nose area.
The stated operational intention is purely preventative, to stop the detained person from spitting blood or saliva at or biting law enforcement personnel or the healthcare workers trying to treat them.
But simple devices can generate intense, polarized debate. There is substantial ongoing controversy surrounding their use. And as we discuss this, we're going to model the professional neutrality required of a forensic clinician.
Our job here is not to take a political side, advocate for a policy, or solve the debate. Our job is to objectively outline the two profoundly different viewpoints so you understand the context, and then focus purely on the clinical implications.
On one side of the debate, law enforcement agencies, security professionals, and many frontline emergency workers strongly advocate for spit guards as an essential, non-negotiable piece of personal protective equipment.
And their reasoning is grounded in occupational hazard realities. Spitting is a frequent, highly weaponized occurrence in volatile arrests or psychiatric emergencies. Saliva and blood present a significant biological hazard.
Officers and nurses face the very real risk of the transmission of infectious diseases, such as hepatitis or HIV, though the actual transmission rates via saliva are highly debated. Regardless, an exposure incident getting spat in the eye or mouth requires the worker to undergo months of profound psychological anxiety, repeated blood testing, and potentially debilitating, nauseating post-exposure prophylactic medications.
From this perspective, the spit guard is a basic, necessary occupational safety measure to protect workers from biological assault.
On the other side of the debate, human rights campaigners, civil liberties groups, and legal advocates express profound systemic concerns about the safety, the ethics, and the psychological impact of these devices.
Their concerns are deeply rooted in international human rights frameworks. They argue that forcibly placing a hood over a person's head, especially someone who is already in a state of acute mental distress, severe intoxication, or panic, is inherently degrading, terrifying, and dehumanizing.
Furthermore, they draw stark historical parallels between spit guards and the practice of hooding in military detention settings, which has been formally recognized by international human rights bodies as a form of cruel, inhuman, and degrading treatment.
And from a purely medical standpoint, critics raise significant safety concerns about airway monitoring.
Yes, there are severe concerns that the mesh material, particularly if it becomes soaked in blood, vomit, or saliva, could obscure a clinician's or officer's ability to see visual signs of impending airway compromise. If a patient is turning cyanotic blue in the lips, or if they begin to passively vomit while wearing the hood, those critical visual cues might be hidden until it is too late, leading to aspiration and death.
This risk is exponentially higher if the person is simultaneously restrained in a prone or awkward position.
So given this intense controversy, what is the core clinical takeaway for our listeners who might encounter a patient wearing one of these?
The clinician's job in the emergency department or the custody suite is not to resolve this global political and ethical debate at the bedside. Your mandate is entirely clinical and forensic. Your job is twofold. First, your immediate medical priority is to ensure the patient's airway is safe, patent, and utterly uncompromised. Remove the guard if medical assessment demands it. Second, objectively document everything about its use.
If a patient presents with a spit guard applied or reports having worn one during transport, you must explicitly document their respiratory status. You must check for any facial trauma, abrasions, or pressure marks from the elastic bands.
And crucially, you must objectively document their psychological state and, quote, any specific distress they articulate regarding the experience of being hooded. You are meticulously recording the medical and psychological facts for whatever legal, disciplinary, or human rights review may eventually follow.
The tissue and the mind keep a record. We just have to write it down accurately.
Okay, let's pull back from the specific devices and look at the big picture summary. The overarching theme of this deep dive, and of Chapter 15 of Simpson's Forensic Medicine, is that restraint is fundamentally about control and safety. It is never legally or medically permitted to be used as punishment.
Whether an officer is using an empty hand arm lock, a rigid steel handcuff, a targeted stream of synthetic capsaicin, or an advanced neuromuscular disruption device, the foundational rule remains the same. The application of force must be reasonable, It must be necessary to resolve the immediate threat, and it must be strictly proportionate.
Proportionality is the exact, unyielding lens through which every single resulting injury must be forensically viewed and analyzed.
And that leads perfectly to a final provocative thought for our listeners to mull over as they process this material. We've discussed a wide array of control techniques today, moving from raw kinetic energy to complex electrophysiology. As restraint technologies continue to evolve at a rapid pace, moving from simple wooden batons to chemical aerosols to smart tasers, we're entering an era of biometric integration.
This is a fascinating frontier. Think about it. We already have smartwatches that track our heart rhythms and oxygen levels. Police forces are beginning to experiment with advanced biometric body cameras that monitor an officer's heart rate, stress levels, and adrenaline surges in real time during a conflict.
It is entirely plausible that in the near future, suspects being restrained might be monitored by those same biometric sensors, perhaps integrated into the restraint devices themselves. A handcuff that continuously reads pulse and oxygen saturation, or a taser that ceases firing if it detects a dangerous arrhythmia.
But the fundamental forensic question will never change, regardless of how advanced the AI or the biometric telemetry becomes. We must always fundamentally ask, was the basic physiology of the human body respected, and what specific objective story is the damaged tissue trying to tell us?
The technology changes, the weapons evolve, but human anatomy and the fragile limits of our physiological tolerance remain stubbornly exactly the same. That is something to keep firmly in mind every single time you walk into a trauma bay, a pathology lab, or a custody suite.
All right, let's transition into the exam prep segment of our show. It's time for learning reinforcement. Let's lock this vital knowledge in. I'm going to fire off 6 rapid single best answer prompts based entirely on the material we just covered. I will pause after each one. If you are driving or doing dishes, shout the answer out loud if you can. If you are in the library, just lock it firmly in your mind before we reveal the answer. Ready? Prompt 1. What specific, pinpoint physical finding is absolutely mandatory for a clinician to actively look for when a patient has been subjected to a vascular neck restraint? Got it.
The answer is petechiae. You must meticulously check the skin of the face, the eyelids, the sclera of the eyes, and the intraoral mucosa. If you missed this, refer back to the empty hand section of Chapter 15 and review Figure 15.1.
Excellent. Prompt 2. Handcuff neuropathy, resulting from tight application or a violent struggle against the ratchet mechanism, most commonly affects the cutaneous sensory distribution of which 2 specific superficial nerves? Lock it in.
The answer is the superficial sensory branches of the radial nerve and the ulnar nerve. If you need a refresher on wrist anatomy and the styloid processes, refer back to the handcuffs section.
Prompt 3. What is the descriptive forensic clinical term for the characteristic parallel lines of bruising left behind by a high-velocity friction lock baton strike? Do you remember the term?
The answer is tramline bruising, caused by the violent displacement of blood away from the central point of impact. This is a classic forensic pattern. Review the baton section for more on kinetic energy transfer.
Prompt 4. What is the actual physical state of the active ingredient in CS spray at room temperature before it is dissolved in its organic solvent for deployment? Think back to the chemistry.
The answer is that it is a solid crystalline powder. It must be dissolved in methyl isobutyl ketone, or MIPK, to be aerosolized. Check the irritant sprays section for the chemistry and pharmacology.
Prompt 5. Which specific operational mode of a taser is fundamentally designed to cause widespread neuromuscular incapacitation rather than just localized pain compliance? Which mode was it?
The answer is probe mode, which fires darts and allows for wide electrode separation across the body, overriding the motor nervous system. Drive stun mode only causes localized pain. Refer back to the conducted energy devices section.
Final question, prompt 6. Prone positioning, massive central obesity, and a subject's hands being cuffed behind their back are all massive risk multipliers for what complex, potentially fatal physiological complication?
The answer is positional asphyxia, driven by the catastrophic mechanical splinting of the diaphragm and the chest wall, leading to hypoxia and fatal arrhythmias. Refer back to the empty hand section for the detailed pathophysiology.
And that wraps up our rapid recall. I strongly encourage you to open up Chapter 15 of Simpson's Forensic Medicine. Review the specific images we discussed today, especially those scleral hemorrhages and the baton imprints, and read the underlying text for yourself to build your own conceptual frameworks. Thank you for taking the time to take this deep dive with us today.